Thank you for your patience. We'll get through the questioning. I'm going to now yield myself 5 minutes, and we'll yield each member 5 minutes, and if we have time, we'll go through a second round if needed, but that'll help us hopefully get through the questioning in case we get called back for another vote shortly. Dr. Edwards, I wanted to talk to you a little bit about your experiences there in Georgia, and you testified that the government's role should be addressing barriers that prevent the use of health technology. From your experiences in Georgia, do you find that the cost is generally the greatest barrier, or what barriers are you seeing in Georgia? And I guess I want to get some perspective in how you see what you've done in Georgia, your experiences could be utilized in us looking at a system that would cover the entire country.
Thank you for the question. Finance for small physician practices is one of the significant barriers. Many of the practices say that it's cost prohibitive to adopt, but the initial investment is not as much the fear as it is the long-term sustainability, and then the fear of a reduction in service and their opportunity to provide services in an economical way. So cost is defined in various ways. One, you have to come up with money to invest in the system. Two, you have to then sustain that system. But then you also have to change your business practices to accommodate a new way of practicing medicine. So the second barrier really comes from whether or not there's a desire or willingness to have an interoperable system that shares information and ultimately, in some cases, reduces duplication and utilization of unnecessary healthcare services. And so the fight or the tension between making a system more efficient and then being able to make money creates this conflict and sometimes a barrier to adoption. And so we found both in Georgia, where for small physician practices it could be simply just the upfront cost, but for larger health systems it's a lack of a desire or willingness to want to share information that creates the efficiencies that ultimately reduce healthcare spending.
Well, right now we have a fee-for-service, so the more services we can give, the more money you can make. And let me ask you then, as you look at that being one of the barriers, do you see the barriers at all broken down by maybe age of the practitioner, or do you see it broken down at all by specialties? Is there any differences there?
Age is interesting. I have actually had in my small business practice where I'm helping them implement technology, providers say, I will either retire or die before you make me use a computer. So I say, okay, I don't know which one's going to come first, but your business manager has already made the investment. So I've had older physicians say that they're just not inclined to want to use technology as part of their practice. So that is a barrier in some cases, although that's a stereotype. There are some who are more than willing and able to do that. On the other end, as it relates to specialty, and Dr. Stuckey spoke to this very, very well and profoundly. The EHR companies and the vendors have been focusing on ambulatory care in a comprehensive way, but have failed to recognize the fact that different doctors practice medicine differently. And what they chart and record and the information they need varies from one specialty to the next. And I have had with my practices that I've worked with barriers to adoption because the system doesn't accommodate OBGYN charting. Pediatric growth charts, or any other specialty, oral screenings. They don't have the capacity to chart that information in the system, and so therefore the physicians are less likely to adopt. So both of those, age as well as specialty, have been barriers to universal adoption.
But then there's also some intrinsic problems with how we're developing these systems, that it's really
Correct.
not user-friendly to all the different specialties that you might be dealing with.
Correct. It's not one shoe fits all.
And do you think we're going to be able to achieve that in what you've seen so far? I mean, you've been working on this for a while in Georgia.
I'm an optimist, and I think we can. If you think about banking and cell phones, there are a gazillion different types of cell phones, but we're all still able to talk to each other. Mm-hmm. So there could be that many different types of EHR systems that are able to talk to each other if the demand is there. If we as consumers demand to have a more efficient system that's interoperable, that allows us to travel and have access to our information when we need it and where we need it.
Mr. Jackson, you're one of the early adopters of HIT. how much time and money do you estimate it takes you to train an employee? And I know you did bring up one of the things is that there's some staff who you don't think will be able to actually utilize these systems once they're in place.
Yes, what our experience has been is there have been staff members in some of the offices that we have integrated that have elected not to learn the new system because it was so different from what they had spent the previous 20 years doing. In terms of training, I think you're looking from a dollar and cents wise, minimally probably $2,500 to $3,000 per individual to have them functional on a system such as we are using within our hospital.
And are smaller practices going to be able to overcome those kind of financial challenges as you look at that?
I am concerned
cost?
about that as I view it, from the standpoint that, as I had mentioned in my testimony, you're talking really about asking small practices to disrupt their operation. So not only are you going to lessen their throughput, you're going to put additional burden of hardware and software acquisition and the opportunity cost of training, both from the time you take the individual out of being able to assist the physician and the actual hard dollars in training where you have to buy that most likely from the HIT company you've contracted with.
And what do you think could be something we can do here, in government to help assist that? I mean, my father, who lives in Erie, traveled to Detroit this year to see my sister, had some medical issues there, went to Fort Worth to my brother's, had some medical issues there, stopped in Memphis to see my daughter, had some medical issues there, and then ended up in the hospital in Indianapolis on his way back through Detroit on his way back to Erie. So obviously we know a person like him, who's 85 and still traveling around the country, is going to have, obviously when we're talking about controlling costs and not having to have different tests in every single city he goes to, is going to be a huge saver in the end. So, I see the value in this, but what do you think we could be doing here?
I think from a government standpoint, I think there needs to be standardization of the information, how it is stored, how it is transmitted, and I think we have to explore at some point the thought of central repository, and that instead of making it all individually based on the individual physician, either base it on the individual consumer or give a large repository where multiple nodes have access to centralized records.
Okay, I said I was going to limit myself to 5 minutes. I've already gone over, but I want to give everyone a chance just in case we could call back for votes. So I'm going to now yield to Mr. Westmoreland.